So I'm going to record, and I'm going to start the show. All righty.
All righty. So this is a 3-month course in medical school. So I don't think we'll all be sitting here for 3 months. So I'll give a condensed version. It's a little overwhelming when you look at the slide. The point is that the GI tract is expansive, mouth to rectal area. So it's important to be aware of all the different components, and especially in the populations we work with, because 2 reasons. One, they don't communicate well. So if they have any issues anywhere from 1 to 8, they may not tell us. And many of them, if not most, are on medication, which can affect 1 to 8. So there's a lot of reasons we should be at least generally familiar. So we'll start at the mouth and we'll move quickly. The biggest complaint we probably see in a lot of our people are dry mouth. And a lot of people say, yeah, so what? Have a glass of water, have a sucking candy. It's not a big deal. But persistent dry mouth actually is a big deal. It leads to cavities, could be mouth abscesses, a lot of pain, ulceration. So it is a big deal. We want to know if somebody's not feeling well, not eating well. Do they have viral blisters, cankersaurs, herpes, any other reason? So it's just the first spot to think. Esophagus, of course, that's the tube down to the stomach. And there we'll see a lot of reflux in this community. So you can have ulcerations in the esophagus, strictures or narrowing. And those could be precancerous. So those are not also, minor things. In the stomach itself, ulcers, bloating, and pH balance. And a lot of the medications we use can throw all that off. So that's something to keep an eye on. Number 4, the liver. Liver isn't something a lot of us automatically think about when we think about the GI system, but it is connected. And basically the liver does a lot of things, but it produces bile to break down the fats. And it breaks down a lot of chemicals in the body. So when the liver is off, of course, that's going to have a big effect. Later symptoms of liver dysfunction is a yellowing of the skin and of the eyes, fatigue, nausea, but hopefully you like to catch it earlier. Pancreas is where digestive enzymes are made, especially protein digestive enzymes. Small intestine, that's where all the good absorption takes place. When we eat our very healthy diets that we all, I'm sure, eat, and we want to absorb all the good stuff, it's mostly going to happen in the small intestine. And the small intestine sucks stuff up, sends it to the liver then processes it. That's called the first pass effect. So if we want medication to bypass that, we may give it intramuscularly, we may give it intravenously, because that's the first pass effect. Large intestine, which was looked at in Mark, that's fluid balance, water absorption. That is super important, because if the water is flowing through, you're going to have diarrhea, you're going to have malabsorption. If there's too much water absorbed and dehydration, you're going to have severe constipation and pain. And the last area, the anal rectal area, again, that's important for holding the bowel movement, proper hydration of it. And don't underestimate fissures, hemorrhoids, things like that. People like to joke around about that, but it's terribly uncomfortable. And if we have an individual who is pacing around, not sitting, doesn't want to be bothered, we want to make sure we're not missing anything anywhere along this track for them. Okay, nervous system. Most of us, I'll bet if I ask about the nervous system, you're thinking brain. But it's responsible for sending and receiving and interpreting information for the whole body. And that includes the gut. And the gut-brain connection is absolutely critical. More and more research is showing it's very responsible for mental health. Neurotransmitters, I'm sure people have heard of serotonin, dopamine, norepinephrine. What you need to know is 90% of them are produced by our gut, and they exist in our gut. So if I'm prescribing somebody Prozac or Lexapro, I better realize they have receptors for that in the gut. That's why nausea and GI symptoms are a big factor if you go too fast or the dose is too high, because you're overwhelming the receptors along the GI system. You may be trying to hit the brain, but you're also hitting there. So that's why the idea of going very slowly and letting the receptors adjust to it makes a lot of sense. And conversely, when you stop a med, if you stop it too abruptly, those receptors then are also like, hey, where's our serotonin, blocker? And then there's too much. So you're going to see nausea, bloating, diarrhea, constipation, all kinds of things because you have those neurotransmitter receptors over there. So this plays a big role in mood, feeling, and brain function. Dysbiosis, which is misspelled there, is when the bacteria in the gut is out of balance. We'll get into that in other slides, but that's not a good thing. So that's something to be very, very aware of. If the gut bacteria is off, you're going to see mental health symptoms. All right, that's still me. So what creates this when the bacteria in the gut's out of balance? And what it means, first of all, is too much bad bacteria, not enough good, because we have a ton of bacteria in our system, and some we need to live, and some we could live without better. So long-term dysbiosis is a significant thing. And what happens, the lining of the gut is protective. If you kind of, think of it as a sort of a protective shield, and when it breaks down due to irritants, allergens, bad bacteria, well, what could happen? That shield is broken and things make it through the lining and get absorbed. And they could be carcinogenic, they could be toxic on all kinds of fronts. So the type of things we have to look at that can affect it, antibiotics. Well, that's the most obvious, right? Because that is intended to kill bad bacteria. But I'm sure many of you have been to a doctor where they've said, hey, have some yogurt or have a probiotic, because we want to make sure we don't wipe out all the good bacteria as well. Antacids, if you go down to CVS aisle, this country is insane for antacids. Billions of dollars are spent in the US on stomach products, more than any country in the entire world. And antacids are not okay for everybody. A lot of times they can mess up the bacteria that you need by throwing off the pH balance, and it causes more problem. Antidepressants can affect the bacteria level. Laxatives, clearly, amongst a lot of other things, and we'll get into that later. GERD medicines like protein pump inhibitors, that can affect the acid in the pH level. NSAIDs, what that is non-steroidal anti-inflammatory, like ibuprofen, like a Motrin or an Advil. I'm sure everybody's aware that could cause upset stomach, inflammation. But to be more scientific about it, what you're doing is you're also breaking down the lining because it's irritated. So long-term use of those is really, really bad for a lot of people for that reason. Statins too. Diet, nutritional value of what we eat can affect it. Chronic stress. You always read about situations where there's stress in someone's life, and I'm sure many of us have gone through, where you toughen up and you're good. You get through that moment, a loss in the family, a trauma of some sort. Within over the next couple of weeks, you're worn down, you don't feel well. And people love to say, oh, it's a delayed reaction. Well, maybe the scientific basis for that delayed reaction is you've beaten the crap out of the lining of your stomach and your small intestines, and bacteria gets in, viruses get in, and you're more prone to a stomach virus, you're more prone to respiratory virus. Chronic inflammation as well is a really big thing. Infection, like I said, and really, you could be preventative with good diet, exercise, and probiotics for some people could be helpful to maintain the balance. So I threw out a lot. Anybody have any kind of questions on anything? Or otherwise, I think it's over to Elise for the next slide.
I just want to say that was incredibly, really great information. And it helps me just, I feel like all over people are talking about gut issues and things just aren't, I don't know. It was really wonderful and helpful. Thank you.
Oh, sure. Thanks. You're muted.
I was muted because the phone was ringing, so I had muted myself. I just want to also mention that because my screen is shared, I can't see everyone, so you don't need to wait for me to call on you if you have something to say or a question. Just unmute and speak up. And again, like I said earlier, you can definitely use the chat feature. So we're going to move forward a little bit. That was a ton of information from Dr. Kent. And I'm going to talk about what we might notice. So we do work with a lot of individuals who may not be able to communicate uncomfortability or pain or different concerns that they may have. So we want to make sure that we have a good understanding of the symptoms that we may notice as the caregivers and the supporters of these individuals. There is definitely an overlap in some of these symptoms with other conditions. So it's really important to always have that thorough medical workup as well. So looking at general digestive issues, we may see or smell gas. There may be heartburn concerns, acid reflux. There may be constipation, which of course we can note if we're doing bowel movement checks or anything of the sort. We could visibly see bloating. I know when I worked in the group home early on in my career, we had an individual that had a lot of digestive concerns, and she was a very small woman. And when she was bloated, it was very, very visible. And it was something that was on our checklist. So bloating is something that we may notice. IBS type symptoms are things that we can check in on. In looking at the mental health, Dr. Kent talked about that brain-gut connection. So we may see anxiety. We may see some depressive symptoms, a brain fog, OCD type symptoms, a chronic fatigue may be seen, and it might be related to a gut issue. In doing some blood work and some medical workup, they could have a vitamin D deficiency, they could have a vitamin K deficiency, a B12 or a B7 deficiency, as well as a magnesium deficiency. And a lot of that goes back to the earlier slide that Dr. Kent showed about where things are absorbed and where that problem might lie. Also associated with gut concerns could be a skin condition. So we may see acne, rosacea, eczema, psoriasis. The skin concerns might come to the surface that may start in the gut. And then we also can have some autoimmune concerns, so an inflammatory bowel disease, and that's something that can be looked into through, the titers associated. Okay, so just a quick discussion about pica. Mark does have a diagnosis of pica, so it's important to discuss as it can definitely impact our gut health. So pica is an eating disorder. It involves eating items that are not typically thought of as food and that do not contain significant nutritional value. This could be hair, dirt, paint chips, it could be Legos, it could be really anything. We may see some warning signs or symptoms. So that may be persistent eating over a period of at least 1 month of those substances that are not food. The ingestion of substances is not a part of a culturally supported or socially normative practice. So that is always important to be culturally minded as well. And eating of these items are not developmentally appropriate. So we want to ensure that for their developmental age, that it's an inappropriate action. Some stomach symptoms that may include, so a stomach upset, pain, you might see blood in the stool, which could also be a sign of an ulcer that's developed from eating that non-food item, as well as bowel problems. They could have a blockage depending on the item that was eaten, and likely items that are eaten in relation to pica do not break down. So they cause that kind of an issue in that blockage. There are definitely some risk factors associated with pica. And it's the associated with that co-occurring mental health disorder. In addition, iron deficiency, anemia, and malnutrition are two of the most common causes of pica. If pica is suspected, a medical eval is extremely important to assess for possible anemia and intestinal blockages and potential toxicity as well. There are many complications that could be related to pica. So certain items may contain lead, other toxic substances. Eating those non-food objects can interfere with eating healthy food, which can then further lead to those nutritional deficiencies. Eating objects that cannot be digested can also cause constipation or the blockages, as I mentioned. Hard or sharp objects can cause tears in the lining of the esophagus or the intestine as it goes through that pathway. And there also could be an issue from bacteria or parasites if dirt or other objects that may have some contamination, and that can cause some serious infections, which can also potentially damage the kidneys or liver. Jen, I have a question for you on pica for Mark. It wasn't something that we focused on earlier in your debrief. What are the items that he will typically ingest?
He would eat dirt, sand, I believe some pieces of toys. There's a lot of like little items that he could find. Recently, he hasn't been doing because they've been doing a lot more 24/7 supervision at home and at school. So I haven't really heard anything reported, but it was a lot of kind of like what you were mentioning before.
Okay, thank you.
Hey, Lisa, can I just throw out
Yeah.
one quick thing?
Of course.
With my patients, one simple thing I always have them check is battery availability on toys, because that's one of the really more dangerous, and a lot of toys, it's easy to get the doors open and get the battery out. So that's a common one that's kind of preventable if you sort of child-proof stuff with that.
Absolutely.
Yeah.
Okay. So moving into some constipation, which is extremely common in our population for IDD. Constipation is the diminished frequency of defecation, incomplete evacuation, and or stools that are too hard or too small. Something that is often misunderstood that we see a lot here at START is that it doesn't mean that they don't have any bowel movements. Again, it's incomplete. Could also be the size or too hard, too small. So it's important to remember that. For someone that potentially has constipation, it might look like fewer than 3 bowel movements per week, straining while going to the bathroom, lumpy or hard stools, that sensation of incomplete evacuation, using manual maneuvers to facilitate defecation. So we have some of our cases here at START that will do this. And one of the first questions we ask is about constipation and frequency of bowel movements, because that is definitely important. The protruding stomach, gassy, or then liquid stool. So as I mentioned, constipation does occur at a very high rate in the IDD population. It's as high as 75% of people with ID experience constipation on a routine basis. It's due for a variety of reasons, most commonly related to psychotropic medications, poor eating or drinking habits, a decreased fluid or fiber intake. And there are several studies about this topic and the IDD population, and they have associated constipation with increases in behavioral health symptoms among this population. So it is important to always be looking at in regards to behavioral health. Abdominal discomfort is one of the most common effects of constipation and a sign that there may be a concern, and other signs and symptoms. So there may be a behavior change. We may be noticing some gas, poor feeding, even vomiting. Constipation can also produce other health conditions such as GERD, and it can affect the quality of sleep. It's really important to determine a person's baseline bowel habits in order to assess deviations from the norm for that person, because there's a wide range of bowel movement frequencies among individuals. So often anyone that joins our CETs, we often have brain photos. Unfortunately, in this one, we have the stool chart. But this is really important because, like I said, constipation doesn't just mean there's no bowel movement. So this is a lovely image that can really show you the 7 types of stool and that rating from severe constipation to normal. So that separate hard lumps of stool would indicate severe constipation. A lumpy and sausage-like stool could be mild constipation. The sausage shape with cracks in the surface would be considered normal. A smooth or soft sausage or snake-like is also normal. Soft blobs with clear-cut edges is lacking fiber, and a mushy consistency with ragged edges will be mild diarrhea. And that type 7 is that liquid consistency with no solid, and that would be severe diarrhea. So this is really helpful for providers to understand when they are supporting individuals. I did just notice that we had a chat from Eileen. So we reviewed what Mark does eat in relation to pica. And then a very good point from Eileen that it's very concerning that the mother expects him to void every day. And Mark could become very reliant on suppositories if mom is giving them all the time. Very, very true. We are definitely in agreement with the concern regarding suppositories. In the past, even Eileen, she was giving enemas on an almost daily basis, I believe, Jen, correct? Luckily, she is not doing that currently, but there was a lot of concern and a lot of education that occurred of how dangerous that really could be for Mark, and actually making the situation work and him unable to defecate properly. Any other questions before we move on? Okay, back to you, Dr. Kent.
Yeah, I was gonna say that was a really good question, and a later slide, we're gonna talk a little bit about the danger of that kind of stuff. So with primary issues, you see motility problems, and if it's slow, you're going to have constipation and nausea from it backing up. So those are symptoms that you will see if the motility is off. Hypotonia is poor muscle tone. We see it a lot in CP with muscles, skeletal muscles. See, it's easy to tell the person isn't walking well. They don't have the upper body strength. But hypotonia could be along the bowels too. And those muscles don't have the proper tone, and they won't be as effective. So it will come out with constipation. Neuromuscular means there's a problem at the point where the nerve innervates the muscle. The muscle may be perfectly fit, but the nerve isn't sending the right signal. So the muscle can't do its thing. Metabolic, toxic, and allergic all can decrease the effectiveness of GI functioning. Diabetes is an example of metabolic / neurologic, because what happens is there's not enough blood flow in very small capillary areas, and it damages the nerve. So there's nerve dysfunction. That's why you also see diabetic issues in the kidney and also in the eyes, because there's very small blood vessels, and the nerves to them need to be properly nourished. Toxins damage the nerves and the muscles, so that's important to know. One of the things that happens that can cause constipation is lack of urge. There may be nerve damage and you just don't feel the sense that you need to go, which is clearly a problem. And that is associated with certain syndromes. I obviously manifested my expertise in syndromes before because I had no answer to that other question, but it is important to look at syndromes and see if they are associated with GI problems, because some are, and that may be part of the explanation of why the individual is struggling so much. Secondary, what could we do that's not primary to the muscles of the bowels? Fiber level is very important. Fluid balance is very, very key. Mobility, I find that people that walk more, exercise more, that tends to help keeping the flow of the GI system as well. And we got to be aware of scar tissue. If there was any previous surgeries or anything of that sort, that can affect the muscles and how it pushes the feces down the path. So a lot of factors, some primary, some secondary, but all to keep in mind, because as Elise said, the constipation is so prevalent in this group.
Okay, so continuing to talk about constipation, there are ways to prevent it. So we definitely always want to encourage a well-balanced diet, which anyone that works in this field knows that it can be very difficult in this population to have them deviate from, some preferred food choices, but that well-balanced diet is definitely a very important aspect. Movement, physical activity, Dr. Kent just talked about that when they're immobile, how that can impact them and be a risk factor. So integrating physical activity into the day, whether it be even just taking a walk, Zumba, whatever they can enjoy, moving their limbs, getting their body moving. Trying probiotics, Dr. Kent did talk about that earlier, how that can help maintain the positive bacteria in our body. That is definitely necessary. Being aware of sodium intake goes along with that well-balanced diet. Increased sodium can definitely impact having constipation. Increasing your fluid intake, also a difficult task at times within this population, and making sure that fluid intake is water, is things that can really promote hydration. Discouraging alcohol consumption, ensuring that our population is not utilizing alcohol. Tracking bowel movement. So this is incredibly important, especially for someone that is struggling with constipation. As I talked about earlier, kind of after 3 days, it's something to be looking at. So we really want to always know if this is a concern, how often. Here at our resource center, and I'm sure anyone else that works within group homes, there's always bowel tracking for all of our individuals. Even here, we have a description of what those bowels look like because of the chart previous as well. Because just because they're going doesn't mean that there's not a concern. Supporting regular bowel habits, toilet training, that withdrawal, withholding, excuse me, that Mark does is obviously of concern. So really supporting that regular bowel habits. And then considering stool softeners, obviously important. Sometimes it is necessary. Again, back to Elaine's comment and things that we've definitely talked about internally, and we will continue to talk in this presentation, is the frequent use of suppositories, and in the past enemas, is really concerning in the case that we're discussing, because it can really impact Mark and his ability to defecate appropriately. But stool softeners within a doctor's direction may be necessary.
Okay, well, this first demonstrates that New York Start doesn't assess maturity when they hire a medical director. But aside from that, it answers the question of the risk overuse of these things. And we see it a lot. A lot of families really panic. They're very OCD about has to be every day, has to be a certain quality. And there really is natural variation because if you overdo the laxatives, what you could do is you damage the muscle tone. Over time, the muscle doesn't keep its intrinsic tone, so it dilates. And because it dilates, then what's going to happen is the excrements just kind of flow out. It won't be held, and then you'll have leakage, which is really not a very pleasant thing. And you won't be able to take a normal bowel movement. And more than that, the fluid loss and the electrolyte loss is no small matter. With the electrolyte loss, you could throw off cardiac function. It could be very, very dangerous. And the part I didn't put on here, but is the psychological trauma, of somebody constantly giving you enemas. That's not to be overlooked. It's really a very, very poor strategy. And we have to always remember to ask the families, and sometimes they're forthcoming, sometimes they're not, but we have to try to stay on top of them. And I think generally it's usually from a good heart, and they mean well and want their individual to be healthy. But I'll sit down and I'll, just like in this slide, I'll go over a list of these are the dangers. So we have to weigh them. If your son or daughter or whatever goes every third or fourth day versus every day, well, look what we're also avoiding by not overdoing the supplements, the laxatives, the enemas. So this is a critical line of questioning for anybody when they're working with a family to make sure that this isn't happening. All right, GERD, I think everyone's pretty familiar. That's also, it's the other end on our individuals, but very common. This involves the stomach contents popping back up into the esophagus. If you think of the esophagus as sort of having like a trap door at the bottom, the food kind of comes down with gravity and a little bit with muscle tone, empties into the stomach, and then it should kind of come back up and maintain its integrity. But in some people, it's floppy, it's off a little bit, and the food could be propelled back up with acid into the esophagus. So what happens is you get heartburn, you could get regurgitation, but I really want to point this other stuff out, that you can get asthma symptoms, coughing, hoarseness, sore throat, and chest pain. This is classic from GERD. This is not unusual from GERD. I have a patient right now who is in speech therapy for GERD. She had where her voice was, her larynx was so damaged from the stomach acid, but she never vomited. She didn't have the classic heartburn, and she really baffled a lot of doctors until they kind of figured this out. It's like the knee bone's connected to the ankle bone. Well, the larynx is connected to the trachea, to the esophagus. It's all there anatomically. So you just think of this acid washing over that area, and for her, it was just her voice that went. She couldn't get the volume up. Elise mentioned before the incidence of these things, constipation, GERD, they're very high. GERD may be upwards of 50%. And you always have to wonder about these numbers because people don't report, so I think it's probably higher than lower. When we do consults, I always try to have people look at behavioral health symptoms and relate it to the time of day, because it may relate to eating. And if someone has GERD, the odds are, common sense wise, after eating, you're going to feel a little worse than if you didn't eat all morning, because there's really nothing to wash back up into your esophagus. Last thing, an old study, but it's about food refusal and GERD. How many times do we get called at the group home or the family? Oh, they're being oppositional. They don't want to eat. Oh, he only wants pasta. He won't try anything else. But we have to make sure we're not missing GERD, because if they're getting all this reflux and they're feeling really crummy, they're not going to want to eat. So if the GERD is eliminated, you're going to reduce the behavior or eliminate the behavioral health symptoms. So we never want to just assume it's oppositional behavior and not think about this.
Absolutely. All of these are such great points. And as I'm sitting in our resource center here for START, a lot of this is stuff that our staff will bring back to myself or Jillian, the resource center director, our coordinators. We had a young woman here about a month and a half ago that after every meal would complain of chest pains. And, we had to assure her that she was safe, that she was, we knew that wasn't necessarily of concern. But we also looked at her diet and she liked a lot of hot sauce. And it was only after meals. It dissipated after a little while. If she got, something from the nurse for, what we were assuming was GERD and heartburn and all of that, she felt better and she no longer had a heart problem, was what she would say. And so we did a lot of education and support for her group home about that consumption, and actually worked with her on like measuring out how much hot sauce. So we're not completely restricting it, but let's not use, an excessive amount. Also, hot sauce and spicy food was part of her culture. We don't want to obviously diminish that, but we wanted her to feel safe and healthy. So definitely something that we have noticed here. And even again, a lot of individuals come into the resource center with very restricted food intake. And when we see a lot of carbs, it's not always just because that's all they like. Could be because of the impact of other foods potentially on those GERD symptoms.
Hi, I have a question about that.
Absolutely.
I have a couple of cases that do have GERD myself, and it's the exact opposite of food refusal. It's more so they want the things that make their stomach upset. And it's a matter of, well, it's their favorite foods. It's nothing to really, you can't really argue that, because that's something that they will always eat. And a lot of the residents that I work with, or even the families, tend to give them the foods that upset their stomach, because it kind of alleviates the stress factors that is placed on them in the moment, which reduces escalations. But I was wondering, and it was really interesting that, you're limiting, not necessarily taking it entirely away, the hot sauce, if that can be applied to essentially like all GERD cases, because I'm definitely trying to explore ways to really implement a good diet for them to not only make sure they feel fulfilled emotionally, because it is comfort food for them, but also to ensure that they're not feeling sick.
Yeah, I think that's a great point. I think that everyone is different. So we were able to find with this individual that I was speaking of with the hot sauce, that if she ate it in extreme moderation, she didn't complain about those, again, she would say about as chest pain. And she would, run to the office of, my heart doesn't hurt. And she had a smaller amount of hot sauce. But everyone is different. But, again, I don't know if Dr. Ken has anything to add, but I think kind of exploring that with each case, talking to their providers. I know one of the cases that you're probably thinking of is with soda, which is also your CET case in a few months. And so I wonder if, a small, like one of those mini cans of soda that are very, very tiny would be enough for her to have that satisfaction, but maybe not cause the symptoms. And I think that's really a little bit of trial and error, working with the medical providers, and really understanding, again, not completely 100% limiting that's going to also cause behavioral health symptoms, but also keeping them medically healthy. Dr. Ken, I don't know if you had anything else that you would add on that.
I think it's a great comment, and it's a systems question, because
Yeah.
you don't want to be black and white.
Yeah.
You want to come up with the gray area, and it takes time, and some providers don't always have or want to discuss it. But you want to give a little control to the individual, that they might be able to pick out, hey, I want this, and then you explain to them when you eat it, maybe you eat it with something else that blocks the negative effect, so you can work on it. But just that we're sitting here discussing it, you're ahead of the game. Because a
Yeah.
lot of the times it's not discussed, and it needs to be.
Hey, Lisa, can I add something to that?
Of course, Dawn, go ahead.
I was gonna say moderation is definitely one route you can take, but also is just offering choices that maybe they haven't been exposed to in the past. Like, for example, soda is something that historically children have always had, et cetera, so forth. But there's so many variations of options where, like, if you introduce, like, obviously not with GERD, with lemonade, or, but like, you know what I mean, different juices or things like that. Sometimes it's just having something special that can really meet that need, but they've only been exposed to soda. And especially in group homes, unfortunately, a lot of times they go the path of least resistance. Everybody likes soda, we're gonna get soda, that's great. You can sometimes have to expand their mind a little bit and realize the connection of trying to create more choices and how that's gonna benefit them down the line by making that small amount of time now and effort to find something different, how it's gonna help them in the future.
A great point, Dawn. Thank you. Great questions. Before we move past GERD, are there any additional questions or comments? All right.
All right, so we said before how the brain and the gut relationship kind of goes both ways, and I think nothing's more classic than anxiety and GI issues. Anxiety can lead to the GI symptoms, but the GI symptoms can lead to anxiety, where the person is afraid of getting sick and obsesses. So when we know we have an individual with an anxiety disorder, we need to look for physical symptoms, behavioral symptoms, maybe agitation from discomfort, more emotional from discomfort, crying, sad, or angry appearing. They may not want to be touched. They may not want to be moved. And an interesting reference to it is one of my old favorite Seinfelds. George Costanza came up with this wonderful idea to map out all the good bathrooms in New York. I don't know if anybody ever remembers that old episode, but the reason it was so funny is because it's so prevalent. I cannot tell you how many patients, typical, atypical, it doesn't matter, that their planning is based on what if. What if I get a stomachache at that party? What if I go to the movies or the Met game and I can't get to a bathroom? You know, if I'm on a subway and I'm going to get sick. So I think it's something we need to be so aware of, that back and forth chicken and egg relationship between physical symptoms and anxiety, because it's crazy prevalent. It really is.
Yeah, just on that, I had a neurotypical client in my private practice where when she came to me, her psychiatrist diagnosed with a social anxiety. But as I was digging into it, it was really about what Dr. Kent just said. She didn't go places that she didn't know that she would have access to a bathroom. If it was a long car ride, it was all gut related. And she wasn't even able to 100% kind of discern that. So we took a lot of time in our therapy sessions to really understand that. And then we had her go to a gastroenterologist. And you know, her social anxiety that she was diagnosed with was really altered. There was definitely an anxiety piece, but it was related to her gastro issues. So that is so important. And working in the group homes early in my career, we had one young lady that she always had to know where the bathroom was, wherever she was. She would go places, but as soon as she walked into a restaurant, she used a communication device and she would ask, where is the bathroom to the host? If it was a theme park, we would look at maps of places that had maps. So she knew exactly where all the bathrooms were. She was happy to go as long as she had that information. If we couldn't provide it, she wasn't going. So again, it just kind of shows that gut connection with mental health as well. That would seem as anxiety, but it's very much gut related. Just moving into kind of those physical symptoms with this link. So we talked about some of the muscles and the hypotonia earlier. Individuals might show with stiff or tense muscles, especially in the neck and shoulders. They may have headaches. They may have sleep problems. We may see some shakiness or tremors. There could be a weight loss or weight gain, and a restlessness. And with everything that we're talking about, like I said earlier in the presentation, there's an overlap of a lot of different diagnoses. So that's why it's so important to have that thorough medical evaluation. Behaviorally, we could see actually some procrastination, some lack of motivation, some grinding of teeth is actually something that might be seen in relation to this gut-brain connection with anxiety and digestion, difficulty completing tasks or assignments, we could see taking up kind of some of those maladaptive coping skills with drinking or smoking, an increase to desire to withdraw, and kind of related to what I was talking about before with maybe some what would be looked at as social anxiety. And then emotional symptoms, we may see some crying, overwhelming sense of tension or pressure, trouble relaxing, nervousness, a quick temper, an increase in aggression, potential depression symptoms, poor concentration, difficulty with remembering things and their memory, a lack of or a loss of sense of humor, something that we may lose. And an indecisiveness is another emotional symptom that might be seen.
I don't remember, is this one me or you?
This is you.
Oh, well, all right, well, I'm gonna ad lib this one. I don't remember this one, but okay. It seems like some of this we've sort of discussed about the amount of organisms in the stomach that are needed, the healthy ones. Good bacteria versus the bad. Again, there are bad bacteria, of course, that cause difficulties. Antibiotics could knock them out, but it's really about the balancing act. And again, the intestinal lining is really why this becomes the issue. You know, again, mouth all the way down. It's responsible to keep the harmful substances out of our gut and out of the bloodstream. Keeps the viruses out, the bacteria out. And you had mentioned something before, Lisa, about inflammatory bowel disease. If anyone's ever had a patient or someone in your family with Crohn's disease, that's where they run into trouble. People with Crohn's disease, it's a gastrointestinal disorder, but it's also a disorder of their immune system, because what happens is this lining is destroyed and they're prone to getting infections. And with Crohn's, it could be anywhere where there's mucosal membrane. It could be from the mouth all the way down to the anal region. And I actually even had a patient who had the mucosal membrane of the eyes be infected. So that's just an important thing to throw out. But other than that, I think most of this we've kind of covered on the other slides. Okay, medications. Clearly, as I said, a lot of our guys are on medications, no doubt about that. And side effects are very common. Constipation, well, opiates are, everyone knows opiates cause constipation, but so do other meds like the atypical antipsychotics that we see people on. Certain antidepressants do it. And that's usually because they have what's called anticholinergic effects. They slow down the muscles in the bowel. And they actually also could cause urinary retention because of that. Diarrhea, a little less common from the meds, but it could do it. Stimulants will sometimes cause diarrhea. Bupropion or Wellbutrin, the brand name, can sometimes do it. And on the SSRIs, it's kind of dose dependent and speed of starting it. Zoloft is one in particular. You know, if you start someone on 25 Zoloft, you're going to maybe be okay, but sometimes you want someone to feel better or you just don't know what you're doing and you start with too high a dose of Zoloft and that just kills the lining and you're going to see really bad diarrhea and discomfort. So when you see those symptoms, think of, you know, medication, when were they started, were the doses raised? Again, the timeline of this is super important. Nausea, you know, we said from the slides before, nausea is a manifestation of slowed peristalsis because they're bloated. So if somebody's constipated, their bowel system is moving slowly, it may come out with nausea. Reflux, well, if you irritate, remember I told you guys before about the esophagus emptying into the stomach, you know, with that sort of a chute mechanism. Well, if that gets irritated and gets inflamed, it's not going to shut properly. It's going to hurt. So you might even see reflux symptoms from meds. Motrin, Advil, those are fairly notorious for that. And weight, I mean, weight goes without saying in our psychiatric population, so many of these meds that are calming cause weight gain because they hit the histamine system. And the good of the histamine system is that it calms you. The bad of the histamine system, it makes you hungry and it puts weight on you. And Jen, I think you had said this person was on the hard to pronounce antihistamine at night, even I'm not even remembering doxycyclinate or whatever it was, but that's an antihistamine, so that can put weight on, as can you know, the atypicals. So yeah, a lot of side effects to look out for from the meds.
Okay, so I'm going to stop sharing my screen. I'm going to